We've got much better at making sense of the data that comes off genome sequencing machines. So those machines do complicated experiments and produce data from which we can learn about or read a person's genome, and we're pretty good at that. That's not a completely nailed down problem, but we're reasonably good. The real challenge, as you say, though, is to take that information and work out what it means for an individual, maybe in terms of their risk of disease, what it means for them and their doctors when they're sick, and helping them in treatment. And that's a major challenge for us, and I think we're only at the tip of the iceberg there in terms of what is possible and what I hope will be possible in clinical medicine over the next 5, 10 or 15 years.
And what are the kind of approaches that are going to be used? I've heard people talk about, well, we'll be able to get some understanding of that through big data analytics. And then there was another presentation here about having omics profiles, where you would be able to have a profile of, not just your genomics, but your proteomics and all the other omics that we have out there. Tell us how you think you're going to, I'm assuming you guys are doing this work. How are you approaching it?
So I think it's going to be ultimately an empirical challenge for us. So we're moving towards a world where, at the moment, relatively small numbers, but larger and larger numbers of people will have their genome studied and often sequenced for research or as part of their clinical healthcare. And so within maybe 5 years or 10 years, there'll be increasingly large numbers of databases which link genomic information, all the information in someone's genome, with other information about them, maybe medical tests and so on, or in some cases their whole medical records. And so I think we have to think about a world where that will be the norm. There'll be tens, hundreds of thousands, or even millions of people with genomic data and healthcare data in these large databases, and the challenge and the opportunity for us is to extract the information from those databases to learn how particular changes in someone's DNA might make them more likely to react well to this drug or suffer if they have that kind of treatment rather than another. And those are the opportunities where I think, so some of the ideas of big data and big data analytics will be important, but genetic data has a particular kind of structure, and so some of the expertise we've developed in analyzing genetic data specifically will be important.
And how does the environment and other things that are external to, we think of as external to us as human beings, how does that play a role in the expression of the genome?
It's really clear that many things about us in health and in our illnesses, our diseases, are a combination of the genetic predispositions we inherit and external factors like diet and lifestyle and the environment. And we don't understand that very well at the moment. We know they're both important, that genetics is part of the story, but it's not all of the story. We know for some conditions that there are clear environmental risk factors, smoking and lung cancer and exercise and heart disease and so on. But actually unpicking those, and in particular working out the interplay between environmental factors and genetic risk factors, is something we're just at the very early stages of. But as we amass more data and we get better data on individuals, on their genomic information, the sorts of diets they've had, exercise and so forth, we'll be able to untangle that better.
And I guess I'll close with a question that I know came up when I was in medical school around Huntington's disease. We used to not make a diagnosis of or try and analyze somebody's risk of Huntington's disease if they didn't have it, although they have a family member with it, because it was a devastating disease and there wasn't anything we could do about it. That's certainly going to come up in the context of these genetic evaluations. Is your center or people in your center thinking about those kinds of issues with respect to analyzing the genome?
Yes, as you say, there are very real issues for people in terms of what information they would want to know from their genome and what they wouldn't, and different people will take different views on that. In some cases, that information will be helpful for them medically, in others it won't. In the same way, people have different views about other medical tests, whether to have them and how to get the information fed back. They, as individuals, their clinicians, and us as a society, need to think hard about those kinds of issues. There's not going to be a one-size-fits-all answer, but it's a question of balancing the potential benefits of knowing genomic information with some of the risks and the stresses and the anxieties that it might cause.
Okay, so this has been really an interesting conversation. I think I'll give you the last word. What's your prediction for clinicians, frontline clinicians, about how they'll be using the genetic data going forward? Is this going to be built into our electronic health records and pop up when we see a patient, or is there something else that you think will happen?
I think there'll be differences in different areas of medicine and different medical specialties. I think in infectious disease, where the bugs that make us sick have genomes as well, and also in cancer, where cancer has a genome different from the genome that the person has. They're two areas where in the next few years, I think, genomics will already be starting to impact on the practice of medicine. It is in some of those cases already. Over the longer term, I think in many other areas of medicine, the genetic information, genomic information will be one of the tools, part of the information that clinicians use. Obviously, a challenge for us is, first of all, to help